Welcome. I'm Michelle Kals, Business Director of Business Development with Rogers Behavioral Health, and I will be your moderator today. Joining me are two experts in the assessment and treatment of OCD, Dr. Martin Franklin, Clinical Director at Rogers Behavioral Health's Philadelphia location, and Dr. Jennifer Park, the Clinical Director at Rogers San Francisco East Bay Clinic. Before we get started, I want to give a quick overview of the format. The webinar is scheduled for 90 minutes. To receive CE credits, you must be logged into the webinar for the entire program. We are recording this webinar and will publish it on our website along with the slides for you to rewatch at your convenience. However, please note that the CE credits will not be awarded only if you attend during the live webinar. Doctors Franklin and Park will give an approximate 45-minute or 75-minute presentation. And then following the presentation, I'll facilitate Q&A session. So if you'd like to participate in the Q&A session, there is a Q&A button bar below, and you can send me a message. So you just click on that, ask your question, and we do have many participants today, so we'll try to get it to as many questions as possible. If your question does not get answered, we will record it and send it to Doctors Park and Franklin later. Now I'll turn it over to our presenters.
All right then. Welcome everybody. Disembodied as you are right now, this is an odd experience, but I'm going to speak to the wall and hopefully y'all can hear me well. We're talking today about treating OCD during the COVID-19 outbreak and contamination-related fears specifically. This is the third of a series. We talked about pharmacotherapy last week. We talked in general about treating OCD 2 weeks before that. And right now we're going to be really trying to delve into the treatment of contamination because it's complicated. So we are going to begin. Let's hit the next slide. This is a disclosure slide. We don't have much to disclose. These are our learning objectives. And so we can continue on. Y'all can read that later. This is what we're going to try to cover. And what we're going to really get into in the beginning has to do with the overarching theory. And I want to see how that pertains to what is happening now, because we know we need to modify CBT. The question is how, and then the question is how is the current situation going to compromise our ability to do ERP the way we customarily would, and what are the workarounds for some of that. Okay, so let's hit the next slide.
Dr. Franklin, sorry to interrupt.
Yeah.
We had a couple of people say they were having some problems hearing. Is there a way to turn up the volume or speak louder?
I'll speak louder.
Okay.
How's that?
Thank you.
All right. Wait, no sound? I'm a little confused. Okay.
We can all hear you just
Fair
fine.
enough. I'm gonna bark as loud as I can, and hopefully that'll cover everybody. All right, so let's hit the next one. I always start here, which is emotional processing of fear, exposure to corrective information, Foe and Kozak. This is the theoretical foundation of everything that we do in ERP. And I want to go to the next slide and highlight the most important pieces of this paper. So 1986, Psych Bulletin, what they suggested was that 2 conditions are necessary to provide people with an opportunity to be exposed properly to corrective information. The first thing you need is you need to activate the fear structure. I'll give you a good example. If I'm treating a dog phobic and I bring the person into the room and there's a dog in the room and the dog is asleep and is 15 years old and is like an old throw rug, I don't know if I'm going to necessarily be able to activate the fear. So the person's fear isn't activated with this old 15-year-old dog laying on the carpet. So that's going to be a problem. I need to activate the fear. So I may need, in that case, to move to a more active dog. The second thing I need to do is I need to be able to incorporate incompatible information into the fear structure. So what that basically means is if I come back into the room and I've now got a dog, and the dog attacks you and rips at your arm and causes you to bleed, then we've done, yes, we've activated the fear structure, but we have not exposed you to corrective information. So we need both things. We need you to be activated. We need to be anxious, and the irony of this is not lost on us. I tell this to patients all the time. In order for us to treat your anxiety, we need you to be anxious. The cure for the fear is the fear. And I spend some time talking about the fact that we're not going to do the worst thing on the first day, but we are going to need the fear. And the second thing is we need to go into situations with an idea of what you're afraid was going to happen, and then to see whether or not those things occur. So in the dog situation, they go into the room, I've got an active dog, the person's afraid that they're going to get attacked, they don't get attacked. That provides some incompatible information for the fear structure, but obviously one dog's not going to do it. I'm going to need to generalize across dogs. So this process is indicated by between session decreases in fear. So I bring in 18 different dogs, you're not afraid of any of them now. My guess is we've provided you with enough incompatible information to weaken the fear. We also need to see changes in your cognition. So that's where we get into some things that are going to be relevant here. Is I need to be able to show you that the bad things don't happen. You need to be able to conclude that maybe this wasn't as dangerous as I thought. So we'll have to think about how we do those kinds of exposures in a circumstance in which some of our key procedures are going to be limited in how much we can use them. Okay, next one. So the key procedures in ERP, or call it what you will, CBT for OCD, exposure response prevention, exposure in vivo, which is doing the thing you're afraid of. Whatever you're afraid of, we got to go find that thing and go do it. We have to be around it. You're afraid of snakes, I need snakes. You're afraid of contamination, I need to be around contact with contamination, and that's where we get into some of the nuances now. Imaginal exposure is an adjunct to in vivo exposure, which is imagining the worst case scenario. So if you have a specific feared outcome, we can expose you to that. So if you are afraid that people are going to get into accidents because I say it, then I can say, I want my mother to be in a car accident. I think my mother will be in a car accident. I can begin to build from there, and then telling a fairly detailed story, if you will, a script of how that were to occur, and give you an opportunity to read that script again and again and again and again and again until it gets boring. So imaginal exposure is another method to help us with being in contact with the fear, activating the fear, and after you've listened to it 40 or 50 times, in all likelihood, the activation level is going to be lower, and you're going to learn some things about the fact that you can actually tolerate listening to this. And it doesn't mean it's going to happen. You can tolerate listening to this, and it doesn't mean that your fear will stay up forever. So that's what imaginal exposure can assist us with. If you don't have feared consequences, if it's more of a not just right discomfort thing, then I don't tend to use a ton of imaginal, but imaginals can be very important in lots of different presentations of OCD. Ritual prevention, which isn't really prevention, it's more like encouraging people to refrain from their compulsions and other forms of avoidance. I don't block people, I don't force people, I don't turn off the water, because I want you to be able to make a voluntary choice that if this comes up, this urge to ritualize, I'm going to choose not to. I'm not going to feed the OCD. And there's a lot of psychoeducation around why we do that, why that procedure is important, and then a lot of encouragement. And the language I use for ritual prevention is I want to reduce and ultimately eliminate compulsions. Because I don't expect me simply saying you should stop doing your compulsions is going to work right away. Usually it doesn't. So I have to encourage patients to shape up their behavior such that they start to resist more and more and more, get that resistance ratio up to 75, 85, 95%. So most of the time when you have an urge to ritualize, you don't. And then that leads to some subsequent reductions in fear. Okay? So those are important procedures. Cognitive methods, I think what I would say here is the way that Foa and I have described this in other places, is that we use cognitive methods to augment exposure plus response prevention rather than to replace it. I know there are more formally cognitive therapies for OCD, but in terms of what we customarily will do, I'm going to be interested in your cognition. And Foa and Kozak were really clear about that. Exposure to corrective information, I need to know what you're afraid of. And I need to know if what we did in our exposure confirmed or disconfirmed those beliefs. So if we sit on the bathroom floor, for example, and you thought you'd be throwing up within 5 minutes of doing so, after 30 minutes, I'm going to turn to you and say, what do you make of this? You told me we'd be sick in 10, 15 minutes, and we're still sitting here. We seem to be fine. And if that was their fear, then you've got a nice opportunity to disconfirm. If their fear is that they're going to be sick in an hour, then we have to wait that out. We have to tolerate the discomfort, and then we have to really give a good test of the hypothesis. So think about that. If they think they're going to be sick in an hour, and we're sitting for 20 minutes, and then they go and wash their hands or they shower, then they've basically robbed themselves of an opportunity to be exposed to incompatible information. Because if they don't get sick, now their belief might be that, well, I didn't get sick because I washed. Okay, so we want to pay attention to that. All right, next slide. All right, so symptom subtype. I'm talking about primary obsessional fear here, largely the way that this is categorized in the research literature. So does the symptom subtype matter with respect to the ERP outcomes? So we're going to get into that a little bit, but I do want to sort of slow us down a bit and talk a bit more. Let's take the next slide about this. This is a quote from Steve Holland, who's one of the luminaries in treatment outcome research. He's an adult depression cognitive therapy guy, but he's also run randomized controlled trials for the last several decades and really is an expert in these areas. And what he said, I was at a lecture once he was presenting, and what he said was, every moderator that you find represents a mediator that you've not discovered yet. Now, what he means by that, let me go back through the definitions a bit. A predictor is basically something that it's a variable that tells you that someone's going to be more or less responsive to all treatments. A moderator means that a person's going to be more or less responsive to if you have multiple treatments in a particular trial, that a moderator says that the person's not going to do well in treatment A, they're going to do fine in treatment B. And so what Holland is raising here is that the moderator is important. I want to know why somebody who has otherwise has similar characteristics of their OCD, that they're responding to treatment A as opposed to treatment B. And that raises the question he's asking, which is mediator. So what variables explain the relationship between the moderator and the outcome? And that becomes a very important issue that we're going to get into. I'll show you some of that from OCD because it really gets to this question of, okay, if a person doesn't respond to a given treatment and I have a predictor that says that they don't, why? Why don't they? What is it about that person? What is it about the treatment that was delivered? What is it about the interaction between the person and the treatment that led us to attenuated outcome? And we did one of these papers maybe 1999, 2000, Edna Foa, John Abramowitz, Mike Kozak, and I. And essentially it was this. We were looking at fixity of belief. So poor insight is another way to put it. So we looked at all of our OCD patients across a pretty large study of over 100 patients. And we looked at their level of insight. And what we know in OCD is that there's sort of a normal curve. Some people with OCD have excellent insight, recognizing the senselessness of obsessions and compulsions. Some people have really poor. Most folks are in the middle. And so what we found was there was a relationship between insight and outcome, but only at the extreme end, only at the level of very poor insight or no insight. And so that to us said, okay, the insight's important. But then it also raised the question of, well, why is it important? How did it attenuate outcome? And the answer is a pretty straightforward one from that trial, which is it attenuated between session compliance. So I'm afraid, I'm 100% certain I'm going to die if I touch this table. Guess what I'm not going to do when you're not standing over my shoulder? I'm not going to touch the table. If I don't touch the table, I'm not getting enough exposure. I'm not getting enough exposure. I'm not being exposed to corrective information. If I'm not being exposed to corrective information, then my fear cognitions stay alive and I don't get better. So that's what we're looking at. So when I'm finding a moderator of treatment outcome, I want to know what's the mechanism by which that is being realized. So now we'll go to the next slide. So hopefully that makes some sense. So this is a study we did. It's actually the same data set. These are adults treated in our open clinic. This is Abramowitz et al., JCCP 2003. This is a subtype examination. We had about 130 patients because we also took some patients from the Mayo Clinic, which was where John went next after leaving us for postdoc. And so we had about 130 some odd patients in here, and we characterized them each by their primary obsession. And you can see there's sort of a range here and a reasonably even split across those categories. So at pre-treatment, we see that there's no large differences between the groups in terms of symptom severity on the Y box. Obviously, higher is worse. At post-treatment, there is. And at post-treatment, what we found in this particular trial was that hoarding didn't respond as well to standard intensive ERP. So 2 hours a day, 5 days a week for a month. Hoarding, we had an attenuated outcome. And we're not the only people to see that. We were one of the earlier groups to find that. But what we also recognize now is, in fact, DSM-5 has moved hoarding out of the OCD category because there's some important distinctions between OCD and hoarding that maybe led us to maybe this isn't the match in terms of treatment that we really need. Maybe there's some special procedures that we need to use with hoarding that we don't need to use with every other type of OCD presentation. So this raised the question for us. It had something to do with what happened with hoarding later as the literature grew. But it raises this question, okay, so, and it raises the question I'm going to get to in a minute, which is the relationship between outcome and subtype across other trials. So can we hit the next slide? Okay, so this is not an inclusive list. This is a pretty large literature. I picked a couple of key trials that had contamination cleaning patients. So fear we didn't distinguish in any of this between whether or not you had feared consequences. Most people with contamination do have a feared consequence, but certainly not all. Some are just disgusted and don't like the feeling. A lot of people are afraid they're going to get some generic illness. Lots of people are afraid they're going to get some specific illness. So what we found across these trials was that contamination cleaning patients did better in ERP than those who were suffering from unacceptable thoughts. 3 different studies. The last of those was a combination of 2 randomized controlled trials done by FOA and Simpson and Leibowitz et al. In our group, and basically finding that the contamination patients fared better in ERP. The first trial was an intensive trial. The second trial was twice weekly. And in both cases, contamination patients did better, roughly a 50% reduction in their Y-box scores from pre to post, versus about a third of a reduction in the folks who had unacceptable thoughts. So it suggests that subtype matters. But then that raises the Holland question, which is why? So what is it about unacceptable thoughts that makes it harder to treat, especially since most other subtypes were responding pretty well and more like the contamination group? So the question here is a potential confound that we ran into when looking across this literature. The confound is that there are higher rates of mental rituals and fixed belief in the unacceptable thought group, especially those with scrupulosity. So maybe it's not the subtype per se, maybe it's these other characteristics. Mental rituals are harder to stop because the therapist has a harder time seeing them. The patient maybe doesn't even recognize themselves when they're doing a mental ritual. Or sometimes they do and they just don't want to disclose it because it's anxiety provoking to not do it. And we also know from what I said about fixed belief before that if you have poor insight, it's going to attenuate between session adherence to the protocol, which then also could be a mechanism by which treatment outcome is attenuated. So basically, in this study that was done in 1984, FOA et al., attenuated exposure or response prevention could impact outcome. So if your exposures are not kind of going right at the fear and sort of maximizing the exposure opportunities, or your response prevention is only partial, We know from this trial, which was a comparison of exposure alone versus response prevention alone versus combined treatment, exposure plus response prevention, what was found in that trial is exposure plus response prevention did better in the short run and did considerably better in the long run when you looked at follow-up compared to the just do exposure idea or just do response prevention. What does that look like? So if I have contamination fear, I do exposure, I touch things that are contaminated, but I don't get any specific instruction or encouragement to refrain from rituals. Response prevention alone basically means don't wash your hands, don't take a shower, primarily contamination sample. Don't wash your hands, don't take a shower, but you don't have to, you can walk around like this if you like. You don't have to go and lean into the fear, it's just as long as you don't wash. So both of those treatments alone wound up not being as effective as exposure plus response prevention, which is, and this was a really important study to encourage us to do both. You need to do exposure, you need to lean in, and you need to systematically reduce and ultimately eliminate all forms of avoidance and compulsion. That's the treatment. Okay, so let's hit the next slide. So now, this, I'm a native New Yorker, by the way. This, I've never seen this. This is midday on 52nd Street. I think it might be 8th Avenue. I'm not sure exactly. But all I can tell you is it's 3:30 in the morning. This street is jammed. So here we are in the midst of COVID, and you have people doing a good job of following the shelter-in-place order, and you have no people out. And you have very clear instruction, which I'm going to get to, about what people should and should not be doing, where they should and should not be going, when they do go out, what they should and should not be wearing. And to me, that as a person who's interested in exposure plus response prevention, I can see where those requirements are going to have some implications for both exposure, especially in vivo exposure, but also response prevention. What can I tell you to do? But what can I not tell you to do in the context of COVID-19? Okay, so let's hit the next one. All right, so COVID-19, the coronavirus causes COVID-19. So you get the virus, and then if you become symptomatic, you develop this COVID-19 illness, disease. It's viral, so the fact that it doesn't respond to antibiotics should not surprise anybody. And I think that we also know it spreads via direct contact. So if you're walking around in an empty field and not touching anything, the likelihood is it's not going to come from the trees and land upon you. It's not the way it works. So we have direct contact we have to pay attention to that we customarily pay very little attention to unless we have OCD already. We have spreading of contamination via being reduced, prevented, via social distancing and good hygiene. I'll get into the requirements for the CDC or recommendations from CDC in a minute. We don't have, this is an important issue for where we are as a nation, where we are as a world, as far as we still don't have a vaccine, and we still don't have specific treatments for COVID-19. We have treatments for the symptoms associated, but we don't have a treatment that specifically eradicates COVID-19. So that makes this whole proposition like maybe even more important than it would be customarily, because with flu, we have Tamiflu, we have flu shots, we have all sorts of things to reduce the effect of that. Here we don't have any of it yet. Okay? At the same time, I say that, I don't want to lose sight of the fact that there's great comfort in math. Most people who get infected, which is probably the majority of the population, most people who get infected will survive. Many of those people, probably most of those people, will even be asymptomatic. Now, they're problematic because they can spread contamination, but the majority of people who even get infected are not going to die from COVID-19. It's not like the Black Plague. The Black Plague in the 14th century in Europe knocked out 1 out of every 3 living people in Europe. That is not, we're not anywhere near that with COVID-19. And I'm not saying we don't take it seriously, but I am saying that we need to remember this for our OCD patients who might be assuming that if I've touched anything in the environment, it's a death sentence. It's not a death sentence. And there are things we can do about it. Okay, let's go next. So this is straight out of the CDC website. And it says you can help prevent the spread of respiratory illnesses with these actions. Avoid close contact with people who are sick. Sounds reasonable. Avoid touching your eyes, nose, and mouth. I've become very conscious of that on these calls, by the way, on these webinars. I keep my hands down. I'm really trying to bring some examples to roost here as best I can. I'm not sure I would necessarily be touching myself all over the place anyway, but just an example. And what they tell you too is that you should wash hands often with soap and water for at least 20 seconds. This all sounds pretty reasonable to me. I have an idea as a person who's not vulnerable to OCD of what this would translate to in my daily life. I try to be reasonable. I don't take frivolous risks. I don't want to expose myself, nor do I want to expose people I am in contact with to coronavirus. So I'm going to be reasonable about it. But that's where OCD starts to capitalize on the sort of fuzziness of this language is a place where OCD can breed. Next slide. So there's a few things. What's the definition of close contact? And if you have OCD, you might be worried that close contact is we were within 10 feet. And I think Dr. Fauci has been pretty clear it's within 6 feet. And I know that a lot of the public health departments say it's within 6 feet for 10 minutes or more uncovered. That's a person who should probably be tested if that person is known to be ill. The definition of sick. So the COVID-19 and the coronavirus hit at a time when people like me had their usual seasonal allergy issues. So around March, I started to sneeze. Around March, I started to get watery eyes like I have for the last 35 years. Summer in Massachusetts changed me over to an allergy sufferer. But so some of the symptoms that might be customary for me for the first couple of weeks of March with all the plants blooming suddenly became a source of concern for people near me. I'm sneezing, I'm watery eyes. How do I know I don't have the coronavirus? And the answer is I can't be sure. And we waited for the symptoms to mitigate. They did indeed. Doesn't mean I didn't have it, but what it probably means in all likelihood is I probably had my seasonal allergies. And the problem with this particular illness is it looks like a lot of other illnesses that are benign. So we have all these questions about how to define people who are sick. We have questions if you have OCD, especially of how often should I wash my hands. So when you come in the house, it's pretty clear. They want 20 seconds of hand washing when you're coming from outside to inside. Now I'm inside. Now what? And I think that if I were to follow the CDC, you're in a private home that's not gotten a lot of foot traffic in the last month and a half, presumably, is I'm pretty safe and comfortable in my own home right now. So I don't necessarily think I need to be touching. I'm in my house. I don't need to be washing my hands every 5 minutes. I had somebody tell me, one of my adult patients say, he was carefully following the CDC guidelines. And when I queried about what that meant for him, I asked, well, how many times a day do you think you're washing your hands? And he said, I don't know, about 60 or 70. Like, that's not on the CDC website. It says 60 to 70 is into our territory for OCD. And we had to start looking at where he was being excessive. And some of it was just going too long at the initial hand washing coming in. But then it was, maybe I touched this, or maybe I touched the fridge, or maybe somebody who lives in my home touched the fridge and they were out and they didn't wash their hands. And it was resulting in dozens of hand washes over the course of a couple of hours. But we know ambiguity moves like water seeking a crack. And if uncertainty and intolerance of uncertainty is so central to OCD, as John Grayson and others have pointed out, OCD is going to breed in that uncertainty. So we want to look at these definitions of close and sick and often and make sure that what I tell people is I want you following CDC guidelines and no more. And I'm sure Jen will get into this in much more detail. CDC and no more. The first one of these websites I did, I also said we created a little jingle, which is listen to the CDC, not the OCD. And that's another thing. I'm trying to get people to ground themselves in what's reasonable at this time and not do more than what's reasonable or necessary. Okay, next one. So we certainly have, in the context of the coronavirus and the COVID illness, increases across the board in contamination fear, excessive social distancing for some people, a subset. I think if you're vulnerable to this anyway, you're more likely to be significantly exacerbated. If you paid no attention to this beforehand, you might be a little more aware, but I don't think everybody's going to rise like the tide to the same level of concern. Just temperament matters in this context too. Internet-based research to decrease uncertainty, and the irony of that, it usually increases uncertainty. Excessive showering or washing now makes you feel like you have to keep that up in order to guarantee safety, and then you wind up on this treadmill where now you don't feel safe unless you're washing. And reassurance seeking from knowledgeable others and even from less knowledgeable others. You see that a lot too. And all of this stuff could occur in anybody, but I think it's more likely in those already with contamination fear, washing compulsions, and avoidance, which is why we're talking about it in the context of treating patients who already have OCD, and now this is another piece that they may need to navigate. Okay, next one. So we're trying to talk to people about what's possible versus what's probable. This is not a death sentence. Doesn't mean we shouldn't take it seriously, but it's not bubonic plague. Acceptable versus unacceptable risk. What's a reasonable thing to do? If I'm going to visit my elderly father-in-law, I'm going to need to be really conscious about that and cautious about that. Social convention and current societal norms, I've certainly seen some of that. People in the community maybe responding to somebody who doesn't wear a mask or doesn't seem like they're socially distancing in a very aggressive and anxious way. That's something else people need to pay attention to. And just sort of a generic comment here, which is even though it's unlikely you'll get it, it's unlikely that you'll get other people sick from it. And even if we do wind up getting sick, it's unlikely you're going to die or that you're going to have some serious outcome. We have to all consider whether it's a chance you should take in the midst of an actual pandemic. And the answer is probably not, but the answer also has to be grounded in probability and grounded in what's reasonable, as opposed to what it's possible we could die, therefore we should treat it as if we're going to all die. I don't find that especially helpful. And I certainly, as a parent, don't find that especially useful to pass down to the kids. Okay? Next one. Now, these are there's all sorts of types of contamination, and some of which have no bearing on COVID-19. So if I have essence contamination as my primary issue, which you see a lot in teenagers, they're afraid they're going to turn into kids that are uncool or kids that have characteristics they don't want to have. You could do all sort of stuff around that, except touch the kid. So we have some things we can't do. But certainly pictures of the kid and imaginal exposure with the kid, we could do that all day long. Animal contamination, fear of rabies, if that's your thing, then I think we could probably be, and it's interesting, I think dogs don't seem to get coronavirus, whereas cats might. So we have some overlapping issues there, but I do think we could do some exposure to animals if we have them around. Fear of diseases other than COVID-19. I have one OCD patient who says that COVID-19 just never showed up on his radar. He's much more afraid of getting some contamination-related disease from feces still, and it's not COVID-19. So nothing has changed in what we can do with him. He needs to continue to do bathroom exposures in his home. He just can't do them at Target. So we have some things we're going to limit. Mental contamination, as Rockman has talked about, we certainly do all sorts of exposure to that. We've had some interesting cases over the years, contamination by places, like the state of Maryland. We had somebody once whose big issue was that the mail would come in, and somebody from the state of Maryland could have touched the mail. So basically all the mail was essentially like being in the state of Maryland. So you can do some exposure to the mail. You can't necessarily do some exposure to the state of Maryland unless you happen to live there. Contamination by the past. That's another one I've seen. I didn't like who I was back then. I've evolved, and I don't want to become like that again. So anything to do with the past, I can't be involved with. Well, I can do a ton of exposure to high school yearbooks, to pictures online, pictures of my neighborhood back in the day, and that doesn't put me in inconsistency with the CDC by doing that. I can do that to my heart's content. And not just write discuss-based presentations, I think are also relatively easy to treat, even in the context of COVID-19. There are limits to what we can do in vivo. And I'm sure Jen's going to talk about that in lots of detail. But to me, I think there's plenty of things we can still do. We do have to be mindful of the fact that we can't do full-on in vivo, the kind that we probably would have back in pre-COVID-19 days, and our response prevention maybe isn't going to be as complete as it customarily would. I do need people to be washing their hands and following the CDC guidelines, but no more. Okay? Next. All right, I'm out. And so Jen's going to talk to you about the more specific contamination stuff, and I'm going to be hanging out here, and I may pop in periodically. Okay?
All right. Thanks, Marty. So I'm going to be talking about modifications to contamination-related ERP in light of the current COVID-19 pandemic. But first, I want to talk a little bit about teletherapy for OCD and the current research that's out there for that. Wooten and colleagues in 2016, they published a meta-analysis of 18 studies. And again, this is specifically ERP-based CBT for OCD. And they looked at a number of studies, one being video conference CBT. That is actually the type of services that we provide here now at Rogers. And that is where we utilize a secure platform to provide video services. And I believe it's something that a lot of providers currently have adopted in the current times. But they've also looked at telephone CBT, computerized CBT, internet CBT, and bibliotherapy CBT. And across these studies, what they found in this meta-analysis was quite promising in that the effect sizes were within the same range for face-to-face treatment for OCD. So you see some pretty effective outcomes in regards to these types of services. But going into a little bit more detail, Storch and colleagues in 2011 looked at family-based video CBT. And again, this is ERP-focused CBT. And in a group of 31 children and adolescents, what they have found was that this type of treatment is very effective for the treatment of OCD. They saw reductions in OCD symptom severity, which was great, but also improvements in impairment as well as family accommodation. And really one of the things that come up a lot in the question of teletherapy is that are the participants or do the patients even like this modality? And what they found in this study is that yes, there are actually pretty high satisfaction rates of this particular sort of intervention, really kind of showing that in lieu of being able to provide in-person services, that this type of teletherapy is effective and it is something that patients are willing and do like to utilize. But in terms of limitations of treatment and ERP in the context of COVID-19, as Marty was talking about, of course, we are concerned about our contamination OCD patients. So just kind of want to provide a case example of one of our patients that we've had. This is a woman and she has that classic OCD obsession of fear of contracting HIV and STDs. She also has a fear of spreading this as well, but of course, in that sort of OCD context, it's a bit irrational in terms of her fear. So she's afraid of spreading it by hugging and touching others as well. And that's how she's afraid of contracting it. Her symptoms are really kind of focused on really severe avoidance. So at the time of presentation, you know, she was avoiding hospitals, doctor's visits. It was hard because she had 2 kids and she wouldn't take them to the doctors. She had to have her husband do it. She would avoid any type of sick people, any public areas. She hadn't been to a public restroom in over 10 years, not even to step inside of them. And she had the compulsions of excessive washing if she ever got into contact with any of these situations, not just for herself, but all her family members as well. So she had kids, you know, when her husband would take her kids to the doctors, when they would come home, they'd have to strip down their clothes, they'd have to wash and take showers, and also, you know, wash their hands when they came in from the outside. Now, prior to the pandemic conditions, she was again doing a lot of the classic OCD exposure and response prevention that you would typically see. And she was progressing really quite well. She was doing a lot of exposure. She was going into the public. She was touching things. She was touching her body and her face. She was refraining from wiping things down. She was able to keep herself from washing her hands pretty much completely. And she was in a really, really wonderful place in terms of her treatment. She had gotten to a point where she was only washing her hands after using the bathroom. And so again, kind of in a good place in regards to managing her OCD. However, once the pandemic hit, we had to modify what she was doing when she did return from home, and to follow the CDC guidelines of, hey, when you're going into these areas, you know, we can't really go about things in exactly the same way. And we want you to start washing your hands once you return from home. Now, in this particular case, it brings up the question of, do we continue with ERP? And for this, the answer is no. And when we ask, well, why not? Well, when you look at all of her different ERP assignments that she's currently working on, all of the things that we would find to be therapeutically beneficial, going out, touching things, going into touching items that are high frequency in terms of a lot of different individuals coming by and touching them, like a grocery cart, like a credit card or ATM machine, or touching money and things and whatnot. These are things in terms of ERP that we would not want to, that would be counterindicated by the current CDC guidelines. Now, that doesn't mean we totally abandon therapy altogether. There are things that are important for us to continue to do during this current pandemic times. And first and foremost is maintenance. So being able to prevent a regression or relapse. And what was really interesting with this particular individual, and actually I'm kind of finding this with a lot of my patients who have progressed quite a bit in terms of their contamination and their washing compulsions, is this real increased anxiety surrounding having to increase their washing. So this particular woman expressed a lot of concern, like, hey, if I have to start washing more than I've already kind of pulled back on, I'm really scared that it's going to be the slippery slope and it's going to snowball into a situation where I can't stop washing at all. And so there comes that balance of being able to ensure that CDC guidelines are followed and that we don't exceed those particular guidelines. So a large part of the focus following the current pandemic situation was about, okay, how can we do exposure surrounding following the CDC guidelines and not doing more than that in order to prevent relapse or regression. Now, in another example, this is a child and adolescent. And this particular individual, he had a fear of getting sick by other people, another classic OCD contamination fear. Also fears of contamination from bowel movements, really kind of using the restroom in general, but bowel movements was particularly difficult for him. And he had fairly significant essence contamination. And the essence contamination was really the piece that was the most impairing for him. He was really concerned about very specific boys at his school. He was concerned on taking on their personalities and becoming like them, and he really did not want that. And it was his essence contamination that really drove a lot of his school refusal behaviors as well as his avoidance behaviors. His compulsions were very complex and intense. He would, after a bowel movement, he wouldn't just wash his hands, he would use Clorox wipes to wipe his hands, causing, a different sense of harm in terms of the bleach that is part of those particular wipes. Not only would he take showers after coming home from school, but he would strip down in his garage naked, then go into the hallway that enters into his home, and his parents would have a set of clean clothes ready for him, in the hallway. He would put on those clean clothes, go into the shower, take a shower, and then put on a second set of clean clothes after that. He also would make sure that all his school items, books, computer and whatnot, backpack, that was all left in the garage. And to accommodate him, his parents had ensured that he had a second set of school books and a second computer that he could use for schoolwork inside the home. So again, lots of avoidance, a lot of accommodation, a lot of different rituals associated with his current obsessions. Now, prior to the COVID situation, he had been fairly successful in terms of refraining from a lot of his compulsions. So he had been engaging in a lot of response prevention related to hand washing, showering excessively, using the wipes after a bowel movement and taking showers. In school, he had started to touch items that his contaminated classmates had touched and was able to refrain from washing his hands afterwards. So we were starting to get him to get into school and start touching things all around the school, the tables, the chairs, and even wipe up near or brush up near the contaminated classmates. And of course, now that we're in post-COVID-19 conditions, as Marty had mentioned before, one of the things that we don't want to assign is specifically having individuals go around and touch other people. So that is something that we had to pull back on and have this individual stop doing. However, with this person, do we continue with ERP? And yes, we absolutely do. Now, how would we go about doing that? Now, a lot of the things we can do, it's business as usual, right? So refraining from excessive hand washing, showering when returning home, that entire ritualized piece that we talked about from going outside to the inside. Nowhere in the CDC guidelines does it say, take a shower, rip off all your clothes, make sure it's in the garage, and then go back inside and then wash yourself that way. We really want to kind of stick to just washing your hands when you enter. But when it comes to essence contamination, one of the things that is limited is our ability to contact or be in contact with those other boys at his school that triggers his OCD. And so we want to be creative. What are the ways in which we can actually target this particular OCD contamination issue? And we can look at the pictures of the students through social media or old yearbooks that the individual, that the child had in his home already. These students dressed in a very particular way, and they also have identified themselves to be gamers. And so things that really reminded this patient of those students was particularly triggering for him. We were even able to find a particular shirt that one of the students would wear on the internet and purchase that and have the patient have that at home to kind of look at and do exposures around. And we also had him start following these students on social media. So Snapchat, Instagram, TikTok. These particular kids were on Twitch, which is the video gaming platform. And so there was a lot of ways in which we can approach these or engage in these types of essence contamination exposures without necessarily actually having to be next to these particular students. Now, with all of these things, we also did imaginal exposures. So taking, holding onto the t-shirt, looking at it, and then imagining and thinking about these particular students, thinking about being contaminated by them, and then turning into them. That was something that was really quite powerful for this particular patient. Now, of course, throughout all of this, we want to be sure to emphasize that we don't want this student to then, again, find this individual, touch them, hug them, or anything like that in order to do in vivo contamination exposures in these types of public areas. These are all things that can be done within the home and in a very safe manner. Now, in terms of limitations to certain types of in vivo exposures, it's hard sometimes to know, okay, at what point can we freely do these exposures in the home? And this is kind of a general overview. This is certainly non-exhaustive, and there can always be exceptions to this, but a general overview of what to kind of look for and think about as to whether or not in vivo exposures in the home is appropriate. One question to ask is someone at home sick with suspected COVID-19? Is the patient, or is there a member in the home, a healthcare worker with direct contact with COVID-19 patients? Is the patient or member in the home an essential worker with contact with large groups of people? Is there a high traffic of individuals who do not reside in the home, but also come in and out of the home? Now, if the answer is yes to any of these questions, then we do not want to proceed with contamination ERP within the home without some extra precautions being placed. However, if the answer is no to all of these, then more or less any type of home-based contamination ERP can continue. Now, there's a lot of different other types of OCD exposures that are limited for us to do at this time. One of the ones is perfectionism, particularly in regards to perfectionism related to evaluation or judgment. And so it's hard to be evaluated on something if your kid's not going to school or if you're not working at this time. But with that in mind, it does not mean that these types of exposures are impossible to do. Again, it just requires a little bit more creativity and a little bit more of kind of shifting in terms of how to engage these specific types of exposures to elicit the same OCD response. So first, I've had some patients write emails and texts with mistakes to friends, family members, therapists, coworkers, anybody that might elicit some sort of fear of evaluation due to the fact that things were not perfect. I've also had some of my patients, when their text messages or phones would autocorrect into something that's actually wrong, to keep it, to just kind of send it off, or to write emails and texts really, really, really quickly as fast as they can and then send it off without being able to look at it or check it or anything like that. Posting on social media with grammar and spelling mistakes, that's definitely something that has elicited a lot of anxiety in a lot of the patients that I've worked with, and has been quite effective in targeting the perfectionism as well as the social anxiety and judgment piece. And another possibility is even sending out a resume to any opening jobs. And in terms of sending this out, if there's a position that the individual is not interested in, but is still concerned about the possibility that somebody might see that they didn't do something perfectly, or that they're not doing things just right, this is a great way to kind of send out something or do an exposure in kind of a real life format, and to elicit that particular OCD trigger. Social anxiety pieces are particularly difficult. It's really hard to do social anxiety exposures when you're not really able to gather in groups or go to parties, or meet new people in person. But again, there are still ways to kind of maneuver surrounding this during the time of COVID-19. Of course, we could call stores, order food from restaurants, hang up, then call back immediately and cancel them. Call restaurants and ask them silly questions like, do you sell toilet paper, or, do you sell groceries? And actually, you might be surprised because some of these restaurants have converted to mini bodegas. So you don't know what the answer is going to be, but it may still elicit the same type of anxiety from these patients. Calling or videoing family members and friends. This actually has been more difficult for a lot of my patients than I had expected. The video component of actually looking at oneself in the camera while also videoing their family and friends has proven to be a really strong and effective exposure, because these patients have, they really oftentimes have this sort of aversion towards looking at themselves when they're in the middle of doing some sort of social anxiety exposure. So this actually has been quite effective and helpful in terms of the social anxiety piece. Another possible social exposure would be, going on a socially distanced walk, and during that time waving hello and saying good morning or good afternoon when you see someone on the street. I know that during my walks, most of us, we keep a wide breath. We kind of look away from one another and just kind of keep our distance and keep in our own little worlds. So this could be a really nice social exposure for some folks. Harm of others. This can be tough, particularly if the harm of others, if that particular obsession is related to, say, something like fear of driving a car because they're afraid that they might run over someone or kill someone, or driving over a bridge because what if they get into an accident or fall off the bridge or fall into the water. And this, in terms of harm of others, this is where imaginal exposures are particularly important and can be utilized. And we can heighten these imaginal exposures in so many different ways. You can heighten them by recording yourself, talking about the exposure, sharing that recording with family members or other trusted individuals, maybe even looking at a picture of the feared event or the feared environment while doing the imaginal exposure. So, if it's a fear of driving over a bridge, looking at a picture of the Golden Gate Bridge while doing the imaginal exposure itself. Other things that people can do is that they can try, if allowed by the context of their state or their city, to be near the triggering environment or in the triggering environment while also sitting there and doing imaginal exposures. So let's say school is something that's very triggering for somebody. They're afraid of going to school because what if they hurt other students, they might hurt their feelings, or maybe they might physically harm them. If it's possible, driving to the school, sitting in the parking lot, and then doing imaginal exposures in that context. And as I mentioned before, most home-based ERP can continue. So if it's any type of harm of others, obsessions that might be related to hurting a family member, avoiding family members for fear of, accidentally stabbing them or doing something like that. These are all things that you can do as usual within the home. As Marty talked about before, imaginal exposures is something that can be utilized. We can repeat it. We can write it down. It's one of those things that we utilize when feared consequences cannot be tested. And this is an environment in which there's a lot of things that we can't test. And in terms of the imaginal exposures themselves, we really, really want our patients to be very detailed about what they're thinking about and what they're imagining and what they're considering. There's a big difference between and I drove a car and I hit a guy versus I was driving a car and all of a sudden somebody darted in front of me and I tried to get out of the way, but I couldn't, and I slammed on the brakes and I could hear the screeching of the tires and the rubber melting on the concrete. And then I look outside and I see a man and he's, completely bloodied, and I think, oh my God, I killed someone. So there's a big difference between kind of doing a detailed one versus a less detailed version of these types of imaginal exposures. And so you want to go towards the more detailed ones because those are the ones that can elicit the most anxiety and be the most powerful in these situations. Again, real emphasis on following but not exceeding CDC guidelines. This is something that I hear probably the most often from my OCD patients, is that they don't know who to listen to, that there is so much information out there that they can't figure out what is real and what is not real. And they have a hard time discerning the two. And because of that, they tend to feel overwhelmed. And so real, clear guidelines are like, hey, limiting the research of COVID-19 stuff in general. You never know what the source is. You never know where it's coming from. So you really want to limit how much information you're consuming. And not only that, making sure that you only get information from credible sources. Another question I get though is, well, how do you know if it's a credible source? If it's really difficult to figure that out, then focus primarily on the CDC website in terms of how you should be, in terms of guidance for your own behaviors. We really want to be on the lookout for our OCD patients because any types of excessive compensatory behaviors, those kinds of things are going to feed into the OCD and it's going to allow it to grow even bigger during this time. So now we're going to talk about adaptations for ERP, for contamination-related fears for youth and families. During this shelter in home, I know a lot of families are stuck in their homes together. And parents are really kind of taking the lion's share of a lot of kind of the stress and pressures in the home currently. And so as providers, it's of course important for us to first validate the concerns that these families are having and to really kind of say, yeah, you know what, you're right. This is something that's really unprecedented. Obviously something's going on out there and it's important for us to keep ourselves safe. However, at the same time, we also want to utilize good judgment in terms of what and how we should change our behaviors. And again, as we've said again and again and again throughout the today, is that following CDC guidelines can be our #1 guiding point in terms of what we should do on a daily basis. We really don't want to understate the idea of commonality, the fact that we are all experiencing this together. I have patients who have talked to me and been like, yeah, and I wonder, when are we going to open again? And when are things, when are things going to get back to normal? And I think about that a lot. And in my mind, I'm like, yeah, me too. I think about that too. I wonder about that a lot too. And, because it's something that we're all facing together, recognizing that we are all struggling and facing our own unique challenges, and having that in mind, recognizing that you're not alone. And that's something that can be very comforting to some of these folks who are struggling at home. Now, differentiating between unrealistic fears and precautions. This kind of goes back into all that information that is out there. I had one of my patients say to me, she had watched a YouTube video that she saw of a physician in terms of how to handle groceries and how to deal with the COVID situation. And she said to me, she goes, Dr. Park, I think this doctor has OCD. And as she was describing it to me, I really could not disagree with her. She was saying that, that he was recommending disinfecting all the fruits and vegetables, using soap to wash everything, to have a contaminated and uncontaminated spaces in the home, just a lot of different recommendations. And one of the things that, again, that my OCD patient said to me, she said, this is too much. I can't do all of these things. And so what I had said to her was, yes, you don't have to do all these things. All you need to do is wash your hands. And that's really kind of the main important piece. So again, some of the things that I've heard from a lot of my patients is I have a patient now who is refusing to drop off groceries to their elderly parent because what if they get sick? And, we kind of talked it through, and what is the probability of somebody getting sick if you were to bring groceries to your elderly parent and leave them at the front door and then drive off? So you're still maintaining that sort of social distance. You're not in close contact with that individual. So there are ways to be able to do this without having to break any of these CDC guidelines. As I mentioned before, folks are showering after returning home from grocery shopping and being out in public in general, even if they aren't around a lot of people. Other things that folks are doing are creating this contaminated and uncontaminated sections in the home. And again, this is something that's a bit above and beyond and not currently necessary. Talked about disinfecting groceries, washing fruits and vegetables with soaps and disinfectants, I have patients who are washing hands between touching each grocery item. So when they go to the grocery store and they come back, it literally takes them maybe an hour or more just to put away all their groceries, because they take one can and they put it away, and then they wash their hands, and then they go back in and they take another can and they put it away, and then they wash their hands. Excessive washing of hands after touching the kitchen or cupboard or refrigerator door. This is even if they haven't been outside. So they just kind of see the kitchen as a general contaminated space. So because their thought process is, well, you know, we had groceries in here maybe like 3 days ago and I had touched all these cupboards, so it's probably still dirty. These are things that are not necessary to do. And then of course there's complete isolation. There are those individuals who have chosen, like, I'm not going to take any risk at all. It's not worth it. And I'm just going to stay inside because the likelihood of getting sick and dying is much too high outside. So those are all examples of things that are a bit more unrealistic in terms of things that need to be, and unrealistic precautions that folks are taking. And what we need to do is a lot more simple than that. Washing your hands once after you return home from being outside, putting away groceries, and then washing your hands just once. And then also practice social distancing. When we go into parent involvement and modeling, this is really, really important, because any folks who have worked with families know the importance and the power that parents' thoughts and behaviors and the impact that has on kids. Children learn a lot of their anxious thoughts and behaviors from their parents and model that type of behavior. And in 2010, Burston and Ginsburg, this was an experimental study. So it's not just association. So we're not just looking at people with clinical anxiety. We're looking at a group of kind of healthy controlled folks who are coming in. And what they had found is that those who were placed in the anxious condition, when their parents modeled anxious behavior and anxious thoughts, the kids then also reported higher levels of anxiety, more anxious thoughts, and then more of a desire to avoid. So it really kind of shows you in this particular context, it really doesn't matter whether or not you have a predisposition to anxiety or not. When parents start to model anxious behavior, kids notice that and they start to feel anxiety as well. So that brings us to the importance of involving parents in treatment. You know, as a lot of folks are well aware, parental involvement in treatment is incredibly important, particularly in regards to reducing family accommodation. Family accommodation, of course, is the act of enabling or facilitating any OCD behaviors that the individual with OCD might have. And in terms of family accommodation, it's really important to make sure that we get a good handle on it, because it's strongly associated with reductions in OCD severity and impairment. And in the context of COVID-19, this does not change. Parents might feel compelled to provide more reassurance to their kids. They might feel compelled to do more for their kids. And it's important to remember them, to remind the parents that this type of behavior is just feeding the OCD. It is not helping the situation in the long run. And eventually our goal is to go back to how things were. This is not our long-term plan. Our plan is that eventually things will open up and that we will hopefully be able to get back to the same types of contamination and other more publicly based exposures as we were doing before. Involving parents in treatment is also really important because we want to be able to provide support for these parents. Like I mentioned before, they're really kind of taking the lion's share of the pressure and the stress and the responsibility within the home. We've got a lot of individuals who are stuck in a small space for a long time, and sometimes these parents, they need that support, they need those reminders. And they also need that psychoeducation, that if parents reinforce anxious thoughts and behaviors or OCD thoughts and behaviors, children will not work to challenge those things. Children will not work to fight their OCD if they feel as though those things are being reinforced. So, general guidance for parents. You can talk the talk, but we also want you to walk the walk. So model the appropriate behaviors. With the parents, a lot of times I suggest to them to vocalize their thought processes so that the children fully understand why they're doing what they're doing. So let's say mom goes out on a walk with their child, and then they come back in and she can say, all right, so well, we were outside and we were in some public areas. So it's important for us to wash our hands for 20 seconds with soap and water. But after that, we're fine. And to be able to just kind of walk them through that process so kids understand why they're doing what they're doing and why they're asking their kids to do specific things. We also want to help parents manage their own anxiety during the pandemic. Again, emphasizing the need for self-care. And I think that a lot of folks here have probably experienced that it's kind of difficult to do that. A lot of folks are working from home. Again, as I mentioned, got a lot of kids in the home as well. There's a lot going on. So it becomes even more important to be able to take small breaks here and there. And then for the parents to also continue to act as a child's coach through these ERP practices. As I mentioned before, these things don't change. We don't stop doing it. We continue to practice as much as we can and continue to keep the OCD at bay so that when things start to open up and loosen up, we can kind of jump back into things and start to do more exposures outside of the home. And finally, we want them to continue to refrain from accommodating behaviors and providing reassurance. Again, this is something that I see that has increased again and more amongst a lot of our families, that they do tend to accommodate more and provide more reassurance because they themselves are feeling that anxiety. But we really want to provide them those reminders that this is something that feeds the OCD and it does not help the child. In terms of preparing families for returning to normative behavior, we want to provide families reminders that current modifications to ERP are temporary. The idea is that we will eventually go back to what we were doing before, and that we're going to use the CDC as a guidance in terms of how we can make adjustments over time. Now, we really don't know when things are going to change or how they're going to change, so we can't say exactly what that's going to look like. But we want to make sure that the families, that the kids and the parents recognize that what we're doing now is not permanent, that we are going to slowly integrate back to how things were before. When things start to open up, it could be helpful to help the children slowly integrate back to their normal environments and to engage in exposures, that may be a little bit lower on their hierarchy by going back to maybe triggering environments by themselves without really doing too much of an exposure. So for example, if a child's main triggering area is a school, again, if that child can then go to the school, before everybody's back on campus, before school has started again, and maybe walk around on campus or maybe even just sit in the parking lot so that they can habituate to those particular environments so that they're not flooded when the schools reopen completely. All right, so I think that's it for us, but we've got our Q&A.
Thank you, Drs. Park and Franklin, for the Q&A. We've had several questions, so we'll get through just as many as possible. The first question is, given the current situation with COVID, should we do more cognitive restructuring with our patients than normal?
Sorry, I had technical difficulties.
There you go.
Oh, go ahead, Marty.
Yeah, I mean, go back to what I was saying earlier about cognitive procedures. I think cognitive procedures are often embedded in ERP. I do think there's potentially the limit on in vivo exposure for somebody who's got contamination fear might lead me to do a little bit more discussion and a little bit more challenging of irrational beliefs in sort of a formal way, you know, the Becky and Sheets, etc. But I think to me, I'm still looking for ways to incorporate exposure into their treatment. I don't want to leave it aside. I want to work around, and I think Jen did a really good job of explaining what kind of workarounds there are. But I don't want to abandon it because we know from efficacy trials that it's a pretty important part, not only of behavior therapy, but also of cognitive therapy. Experiments, behavioral experiments are really important in the treatment of OCD when you're taking a cognitive perspective. I think to do a purely cognitive therapy that doesn't involve any exposure maybe is to exaggerate the risk a bit and might be attenuating your outcome according to the literature.
Thank you. The next question is, would you still recommend home-based ERP for someone with contamination fears who is living with someone who's considered to be high risk, like such as an elderly parent?
I think that it's certainly possible depending on what type of contamination we're talking about. There's a lot of different types of contamination that you can, exposures that you can continue to do without really much concern about how it might impact others in the home. So, you know, if it's contamination, for the example from before, the case example I provided of that child who had fears of contamination from his school, well, you know, he could bring in items from his school that had been laying out in his garage for a long time and bring that in and touch it and not wash his hands, and then, you know, go touch his grandmother or give her a hug without really having to be too concerned about whether or not, you know, COVID-19 is going to be a risk. That is a very, very low risk probability of COVID-19 transmission. I mean, pretty much impossible in that sense.
Thank you. The next question is, will the pandemic result in more OCD cases down the line?
It's a good question, and I don't think we can answer it. I do think that the rising tide will raise all boats, at least temporarily, and not all boats. I think vulnerable boats. Some people are going to be just as impervious during this as they were before it and will be after, and maybe those folks could use a little update on their science. But I do think that there's probably folks who are temperamentally anxious, who might now, this may get stuck in their craw. And then, as Jen mentioned, I think once you start to respond to that anxiety by taking all these evasive actions, you reduce the fear temporarily, and then you pay the price. Negative reinforcement then sets you up for increased frequency and an intensity of obsessions or unwanted intrusive thoughts pertaining to contamination. We won't call them obsessions yet. But we do have an expectation that if exposure reduces it, then avoidance ought to increase it. That's malware two-factor theory. So I would expect some increases. I don't expect it across the whole population. I expect it in folks who might have been temperamentally vulnerable anyway. And certainly if you already have an OCD diagnosis or you have a history of OCD that you've been treated for, I would expect you to be more vulnerable too. And it's all about knowing what your vulnerability is. I don't think we just should be, you know, quaking in our boots hoping this doesn't happen. It's more, okay, this is a thing that I worry about, so let me think about what the experts would say will reduce the likelihood of this blowing up on me. And the answer is lean in, don't lean away. I think there's something we can do about it. It's not, we don't just have to wait for it to descend. It's not like locusts. We can do something about it. And we ought to, if we're in that vulnerable space and we notice our anxiety increasing, we ought to take the proverbial bull by the horns.
Thank you. And there are several questions for parents modeling behavior. A specific one is, in terms of parents modeling appropriate behavior, how should an immunocompromised parent with an OCD child model appropriate behavior when their appropriate behavior is by design more restrictive?
That's a really good question. And I would say that in terms of most kids being able, like I had talked about before, talking through the thought process to the child, and maybe even saying, mommy needs to do things this way, but for you, you can do things this way. And kind of just talking them through what the more appropriate guidelines are for the child, recognizing that maybe mom or dad might have to engage in different behaviors, but they can have that conversation with their child as to this is the reason why, and provide that sort of explanation. And in most cases, kids can intellectually understand that these are the things that can be different from mom or dad because they might be suffering from something different. I think it's important that parents who might be immunocompromised don't kind of overdo it with their kids in terms of that safety piece of, you know, because of the things that I'm suffering from, you now also have to go through all these extra steps and do all these extra different things, because that's not always the case.
Thank you. And a few questions on clarifying the difference between assurance and reassurance.
So assurance is providing, you know, children or others a certain amount of information. It's almost kind of like providing them with information, like, you know, like Marty was saying before, the probability of getting sick from this and dying from it is really, really, really low. And giving them that information. And it's important for them to have, because it's like, hey, what's the likelihood, what's the probability of this happening? And it's very low. Now, if the child then asks repeatedly, do you think I'm going to get sick? Do you think I'm going to die? Do you think what's going to happen next? And you've already provided that assurance, and kind of provided that education for the child. Then what you're doing at that point by repeatedly answering the same question again and again is providing reassurance. And in that sense, it is what the child is then seeking is not necessarily information. What they are seeking is a reduction in their anxiety. They are seeking a very specific response. They want their parent to tell them it's going to be okay and you're not going to get sick.
Right.
So it's a fine line.
And I think a good place to go with that is to, if you already know you've had this conversation, instead of answering the second time or the third time, to say, I think we covered this on Tuesday. Do you remember what I said? And if the kid for kids especially, sometimes kids just flat out don't know. Like I can't assume from a psychoed standpoint that a kid knows or that they remember or they got confused. I want to give them a chance to tell me what they do know. And if they know exactly what I know and what I told them on Tuesday, I'm going to say, remember what I said on Tuesday? We're going to stick with that. And then if they ask me that question again, they might just get a raised eyebrow out of me, right? Like, here again, are we? Like something to shorten that so that I'm conveying to them, you're asking me a question you're going to know the answer to. I also think you got to know your kid's temperament. There's some kids need more information about the risk. And some kids are on the other end of the continuum, are not worried enough. And so with those kids, and again, I'm not going to be able to move that kid who's not worried enough by trying to create anxiety in that kid. It's just not going to work. I have a 16-year-old son, and he has declared himself overtly impervious to all of this. I won't get it. And one could argue with him that you could, but that's not the tack I'm going to take with him. I'm going to spend more time talking to him about good for you, but you may also be carrying, and so I want you to be kind to other people. And he's been much more responsive to I want to be kind to other people and not take a chance with other people than he would in my trying to create anxiety where I don't have it. He's just, I don't know where he got it from, but temperamentally, he is invulnerable to that. It's not an argument that's going to work with him. At the same time, if I'm on the other end of the continuum, maybe I want to spend some time trying to move that kid down and saying, look, I think this is reasonably safe. We're going to take reasonable precautions, and we're going to do the best we can, and we'll figure it out together. assurance, reassurance. I think sometimes for me, what it comes down to is guaranteeing an outcome versus talking about the process. When I used to coach softball, kids would be worried going up to bat. And my kind of reminder to them is, you got this, go, you got this. As opposed to me telling them I guarantee you'll get a hit, because I can't guarantee you'll get a hit. At the same time, I have confidence that you can figure this out, and we'll figure it out together. And I think that's the space I want to try to be in.
Thank you. We have time for one more quick question. This comes from an attendee. I am a generalist who is not trained in conducting ERP treatment. As one of my clients starts to develop OCD symptoms, is it appropriate for me to start ERP after some self-learning, or should I refer that person to an OCD specialist?
And to me, I think it depends largely on your circumstance. If I'm in Philadelphia, Pennsylvania, I can name 25 people within 5 miles of my clinic who can do this stuff really well. And because we've moved to tele, oddly enough, people's wait lists are actually shorter than they have been. And so I could probably find you somebody who could do this. And it's great. It's an aspirational goal to learn more about it. There are a number of opportunities to learn how to do this, but I don't know if I'd want to learn live if I have alternative treatment opportunities right around me. If I don't, if I'm in Idaho or I'm in some other place where I'm unlikely to be able to find somebody, and there are telehealth options available in lots of clinics now that hadn't been available before. But I do think I love the question, because there is some responsibility even for folks who are not necessarily subspecialists, to seek subspecialty treatments and possibly subspecialty expertise when it's evident that somebody needs something like that. And for me, if I have somebody who has obsessive compulsive disorder and I have access to CBT in some way, I think it would be responsible of me to try to find them some way to get access to that care, whether it's me or whether it's referral.
Thank you. And I know we're receiving several questions on if the webinar will be recorded and where to get the slides. And the answer is they will be in the same link on the Rogers website where you registered. And you can also email me with any questions that you may have if you're not able to readily find them. And I just want to thank you again, Doctors Franklin and Park, for taking time away from your clinical practice and sharing your valuable insights with us. I'd also like to let you all know that Rogers is here for those who are struggling with mental health or addiction. And we are still open for inpatient and residential care. And we're very proud to now be offering Rogers Connect Care. It's a virtual option for those needing intensive outpatient levels of care. Doctors Franklin and Park, before we conclude, please share your recommendations on any additional resources for our participants.
So these are some websites that are really helpful. Obviously, we've talked about the CDC a lot, but you can also go to iocdf.org. They often have a lot of great updates there in regards to OCD treatment and just kind of how folks with OCD are dealing with this current COVID-19 situation. We also have ADAA, that's the Anxiety and Depression Association of America. That is also a wonderful website with lots of resources. Both ADAA and IOCDF have a resource directory. So practitioners who, lists of practitioners who are experts in this particular treatment for folks who might be looking for a provider during these times. And then, of course, the National Institute of Health, the NIH.gov, is a fantastic website to just kind of look for more up-to-date science-based information regarding the current COVID-19 pandemic.
And I would add one little piece to that, which is what you should not be exposing yourself to, which is constant, ongoing play of the news in the background. If you have kids around your house, we know from 9/11 studies that was not fabulous for kids. And we certainly also know that there's a vulnerability to misinformation on some of these stations. and you should turn them off so that you're not making things worse, or alternatively, you're not underestimating the reality of the circumstance we're into. I think it's wise to get your news on occasion, and at the same time, don't be beholden to it. You're stuck at home, find other things to do.
Thank you so much. And that about wraps it up, everyone. I just want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. You will receive an email with a link to a mandatory evaluation form. And once that's completed, you may download your CE certificate for the event. We will have a recording of today's webinar and the slides available on our website. And again, that's rogersbh.org. If you are unavailable to join the first two webinars in the series Treating OCD during COVID-19, please visit resources section of our website, and you can rewatch at your convenience. However, please note that CE credits will not be awarded. Next Thursday, April 30th, we'll begin a two-part series on treating depression during COVID-19. Keep an eye on your inbox for details, or you can also register now on the same link to our website. On behalf of everyone at Rogers, we look forward to partnering with you and help you supporting your patients. Thank you very much for attending. And if your question did not get addressed, I will be available to send to the doctors. My email is michelle.cowles@rogersvh.org. Thank you.